Welcome, focused learners, to today's Explainer. Today, we're looking at pharmacokinetics. Now, I know that sounds like a massive, intimidating word, but honestly, it's absolutely crucial, and it's one of the most fascinating concepts in all of medicine. Simply put, pharmacokinetics is the study of what your body does to a drug. Think about it. The second a pill enters your mouth, it's thrown into this ultimate internal obstacle course. Today, we're going to completely decode that journey, breaking down exactly how our biology interacts with the medicines we take. To really wrap your head around this, I want you to ask yourself, what actually happens to a pill after you swallow it? I mean, really happens. You kind of have to think of the drug as this tiny protagonist on an epic quest. It has one specific mission, maybe curing your headache or lowering your blood pressure, but to pull that off, it has to survive our body's incredibly complex, highly evolved defenses. Remember, our bodies are literally designed to keep foreign invaders out, and a drug, well, by definition, it's a foreign substance. It has to survive acid baths, sneak past cellular border patrols, and outsmart massive chemical processing plants just to do its job. Okay, let's dive right in. The foundation of this entire microscopic universe comes down to a really simple four-step acronym, ADME. Every single drug goes through these exact four phases. First step is absorption. That's breaking into the bloodstream. Second is distribution, spreading out to the tissues and organs. Third is metabolism, where your body chemically transforms the drug. And finally, excretion, where the drug gets officially kicked out for good. Together, this whole shebang dictates exactly how much of a drug reaches its target and how long it stays there. Here is our roadmap for this explainer. We're going to track our drug through 1. Absorption, 2. Distribution, 3. Metabolism, and 4. Excretion. Then we'll cover 5 key pharmacokinetic parameters and wrap things up with 6 PK in special populations. Let's kick things off with Section 1, absorption, entering the bloodstream. So, this is the initial break-in. The speed and extent of this step basically decide how quickly you feel better and how much of the drug actually makes it to the target tissue. Now, it's super fascinating to look at the survivors versus the casualties of the gut. When you swallow a pill, it gets absorbed through your stomach or intestines and goes straight into the portal vein. And where does that vein go? Straight to the liver. And let me tell you, the liver acts like a completely ruthless bouncer. For some drugs, like GTN for chest pain, the liver destroys literally 99% of it before it even reaches the rest of your body. We call this high first-pass metabolism. That's exactly why GTN has to go under your tongue to bypass the liver entirely. But on the flip side, drugs like diazepam, they just breeze right past the bouncers with nearly 100% bioavailability. Moving right along to Section 2, distribution, traveling the body. All right, so our drug survived the liver. Now it enters the general bloodstream and starts this chaotic commute through the body's highway system to find its target. To measure this commute, we use something called the volume of distribution, or VD. Now, keep in mind, this isn't a physical space in your body. Actually, scratch that. It's more like a mathematical hypothetical volume. If a drug has a really small VD, it essentially stays parked right there in your blood plasma. But if it has a massive VD, like the malaria drug chloroquine, that means the drug rapidly abandons the blood and hides deep, deep down inside your fat and tissues. So how do these drugs actually travel in the blood? This is a real game changer. Imagine a protein called albumin as a fleet of taxicabs floating in your plasma. Lots of drugs hop into these taxis and bind to the protein. But here's the massive catch. A drug trapped in a taxi can't do any actual work. Only the free, unbound drug is active. And this creates a huge clinical danger. Let's say you have a highly bound drug, like the blood thinner warfarin, sitting in a taxi. Then you take an aspirin. Well, the aspirin can literally kick the warfarin out of the taxi and into the free plasma. Suddenly, boom, you have a massive surge of active warfarin, and the patient's bleeding risk absolutely skyrockets. As it commutes, the drug hits some serious, high-security checkpoints. The blood-brain barrier is like a fortress. It has these super tight junctions specifically meant to block water-soluble, polar drugs from messing with your brain chemistry. But lipid-soluble drugs, like anesthetics, they slip right on through. Then there's the placental barrier in pregnant patients. This one is semi-permeable, meaning it actually lets lipid-soluble drugs cross from the mother to the fetus. This is exactly why some drugs, like warfarin, are incredibly dangerous teratogens that can harm a developing baby, while large molecules like heparin just get blocked at the door and are much safer. Okay, on to Section 3, metabolism, the chemical transformation. So the drug did its job at the target tissue, but it can't hang around forever. It eventually gets pulled back to the liver, which is basically the body's ultimate chemical processing plant. Inside this plant operates a massive machine called the cytochrome P450 system. It's a superfamily of enzymes that chemically transforms roughly 75% of all the drugs we take. Their main gig? Attaching chemical handles to the drug to change it from lipid-soluble into water-soluble. Why? Because water-soluble stuff is way easier for your kidneys to flush out. The undisputed powerhouse of this system is an enzyme called CYP3A4. It single-handedly preps about half of all drugs for eviction. And this right here brilliantly illustrates where so many major drug interactions happen. Sometimes a substance causes enzyme induction, meaning it forces the liver to build even more of these CYP450 machines. Rifampicin does this, meaning it chews through other drugs so fast they don't even have time to work. But then you have enzyme inhibition. Did you know a simple glass of grapefruit juice can completely jam up those CYP3A4 machines? No way, right? But it's true. If you take a cholesterol-lowering statin and drink grapefruit juice, the statin doesn't break down. It just builds up in your blood to really toxic, potentially dangerous levels. All right, let's look at section 4, excretion, leaving the system. So the liver has successfully processed the drug, neutralized it, and now the body has to physically filter and flush it out. The kidneys are the absolute heroes here, acting as this incredible water filtration system to send those water-soluble metabolites out through your urine. But there are definitely other escape routes. Volatile drugs, like general anesthesia, you actually exhale those straight out of your lungs. That's why patients wake up so quickly when the gas is turned off. We also have to be super aware that lipid-soluble drugs can easily leak into breast milk, which obviously creates unintended exposure risks for a nursing baby. Now, here is a seriously cool medical detective trick they use in emergency rooms: ion trapping. If someone overdoses on a weak acid, like aspirin, doctors can actually give them bicarbonate to make their urine more alkaline. Because opposites attract chemically, the alkaline urine turns the acidic aspirin into a charged ion. And charged ions, they can't cross membranes to get back into the blood. So the drug gets trapped in the urine and flushed straight down the drain. And it works the other way too. Acidic urine traps weak bases like amphetamines. Pretty brilliant. Moving on to section 5, key pharmacokinetic parameters. We've seen the optical course, so let's quickly touch on the underlying mathematical rules that govern it. The absolute biggest concept here is half-life. Very simply, it's the time it takes for a drug's concentration in your blood to drop by exactly 50%. What's wild is that for almost any drug, it generally takes about 4 to 5 half-lives of repeated dosing to hit what we call a steady state. That's the perfect balancing point where the amount of drug going in exactly matches the amount being flushed out, keeping the patient in a perfectly safe therapeutic zone. Things like clearance, which is the volume of plasma completely cleared of a drug per minute, and area under the curve, which tracks total drug exposure, well, they aren't just textbook math. They form the literal clinical toolkit that doctors and pharmacists use to calculate precise maintenance doses. When a patient is on life-saving therapy, understanding these formulas ensures the drug peaks at a high enough level to actually work without ever crossing the line into toxicity. And finally, section 6, PK in special populations. Everything we've learned so far assumes you're a standard, healthy adult. But in the real world, this pharmacological battlefield changes drastically depending on the patient. A one-size-fits-all dose, that is a dangerous myth. In elderly patients, kidneys filter slower and liver blood flow drops, so drugs pile up way faster, meaning we always have to start low and go slow. Neonates, on the other hand, are born with completely immature liver enzymes. If you give a baby the antibiotic chloramphenicol, their tiny liver can't process it, causing a highly toxic, fatal backup known as gray baby syndrome. And for anyone with renal failure, any drug normally cleared by the kidneys will literally just bank up in the blood unless you drastically lower the dose. So as we wrap up this explainer, I want to leave you with this thought. We've watched a pill navigate this insane microscopic obstacle course of absorption, distribution, metabolism, and excretion. By mastering these rules, healthcare transforms from a guessing game into a highly precise science. So, how might understanding the unique pharmacokinetics of your own specific body one day unlock truly personalized, incredibly safe medicine? It's a fascinating frontier, isn't it? Thank you so much for joining me today. Keep asking questions and keep learning.